resident from Tata Memorial Hospital, followed by a talk by Dr. Shyam Srinivas, Associate Professor in Pediatric Oncology, Tata Memorial Hospital, who will be talking about options available in relapsed refractory Hodgkin's lymphoma. Following which, we will have an update on INFOC Hodgkin's lymphoma study, which will be done by Dr. Amita Mahajan, who is a senior consultant at Indraprastha Hospital, New Delhi. So I would request Dr. Aditi to kindly take over and share your screen.
Yes. Is my screen visible, sir?
Yes, Aditi, it is.
Should I start, ma'am?
Yes, please go ahead.
Good evening, everyone. I'm Dr. Aditi Dwivedi, DM third year resident from Tata Memorial Hospital. I'll be presenting 3 case scenarios of relapsed refractory Hodgkin's lymphoma, how they presented to us and how we managed them. So I'll begin with my first case. This is an 11-year-old boy who presented to us with right-sided neck swelling for 1 month. There were no constitutional symptoms, no other complaint. On examination, we found right cervical level 2 significant lymphadenopathy. There was no lymphadenopathy anywhere else in the body. There was no hepatosplenomegaly, no other significant finding on the examination. We went ahead and did a lymph nodal biopsy, which was suggestive of Hodgkin lymphoma. So when we did a staging PET, we found FTG-avid soft tissue masses in the nasopharynx, palatine tonsil, as well as right cervical lymph node, level 2 lymph node. So since 2 sites, lymph nodal sites were involved on one side of the diaphragm and there were no B symptoms, he was staged as stage 2A. So he received 2 cycles of OEPA, vincristine, etoposide, doxorubicin and prednisolone. Post that, the interim PET scan done showed good response, adequate response, DS1. On the scan, we can see that these lymph nodal sites, which were initially FDG-avid, have now disappeared. So this was end of treatment for him. We kept him under follow-up. After 1 year, he presented to us with bilateral neck swelling. And again, no other constitutional symptoms, no other complaints. We went ahead and did the lymph nodal biopsy from these neck swelling, which was again suggestive of Hodgkin lymphoma. We went ahead and did a PET scan, which showed low-grade FDG uptake in bilateral lymph nodes. So he was a case of relapsed Hodgkin lymphoma, still stage 2A. He received 2 cycles of IGVD DECA, that is ifosfamide, gemcitabine, vinorelbine, etoposide, cytarabine, and cisplatin. Post that, PET-CT done showed CMR at both these lymph nodal sites with a DS score of 1. He completed his chemotherapy, 4 cycles of IGVD DECA, and received consolidative RT20 gray at these lymph nodal sites. The disease sites had disappeared again. And now he is 2 years post-therapy and is in remission and is doing well. My second case, so again, a 11-year-old boy. So this boy was initially treated outside. He presented elsewhere with fever, abdominal distension, and progressive pallor for 4 months. On examination, he was found to be malnourished. There was pallor. There was no significant lymphadenopathy. There was no hepatosplenomegaly. On evaluating, he was found to have cytopenias. A USG was done for the abdomen, which showed significant lymph nodes, and these lymph nodes were biopsied outside, which was suggestive of Hodgkin's lymphoma. A bone marrow aspiration and trophine was done as well in view of the child having cytopenias, and it was also found to be involved by Hodgkin lymphoma cells. A staging PET scan was done for this child, which showed supradiaphragmatic, infradiaphragmatic nodes along with splenic and marrow involvement. So he was staged as Hodgkin's lymphoma 4BS, Hodgkin's lymphoma high risk. Outside, he received 2 cycles of ABVD, that is doxorubicin, bleomycin, vinblastine, and dacarbazine. Post that, in early response assessment, there was inadequate response with a DS score of 4. He completed 6 cycles of ABVD, but the DS score further worsened. There were new sites of disease which had come up, so his DS was 5. And with this, he was referred to our center. So he was a primary progressive Hodgkin's lymphoma who came to us after receiving 6 cycles of ABVD and had progressed on first line of chemotherapy. We gave him 2 cycles of gemcitabine and vinorelbine. Post that, we repeated a PET scan, which again showed new sites of nodal involvement, and his DS score was 5. He had further progressed on second line of chemotherapy. Then we gave him 2 cycles of nivolumab and bendamustine. Post this, when we repeated a PET scan, all his disease sites had cleared, were in CMMR, and his DS score was 1. Post this, we gave him high-dose chemotherapy with beam, and he underwent autologous stem cell rescue and consolidative RT to the sites of progression. After this, he was put on nivolumab maintenance, fixed dose 40 mg, which he received for 6 months monthly. Currently, he is disease-free for 18 months since his last maintenance cycle, and he's doing well. Now my third case. So this is a 7-year-old boy who did not have any significant past history, presented to us with abdominal lump and constitutional symptoms for 2 months. On examination, he was found to have no significant lymphadenopathy. There was hepatosplenomegaly. Along with this, mass was felt in the left lumbar region measuring 4 into 4 centimeters. This mass was biopsied, and the biopsy report confirmed the diagnosis of Hodgkin's lymphoma. Baseline PET CT showed FDG avid, bulky iliac nodal mass, retroperitoneal lymph nodes, along with splenic involvement. So he was a case of Hodgkin's lymphoma stage 2 BSX. He was treated as per Euronet protocol, received 2 cycles of OEPA. Interim early response assessment was inadequate response. He had a DS score of 4. Post 2 cycles of OEPA, he received 4 cycles of COPTEC, after which all his disease sites were in remission with a DS score of 1. He received consolidative RT to bulky sites. This is his scan after completion of treatment, and he was in remission and was kept under follow-up. But after 5 months, he presented to us again with fever for 1 month and weight loss for 1 month. This was his PET scan, which showed multiple FDG avid hypodense lesions in the spleen along with abdominal lymph nodes. Biopsy again confirmed the diagnosis of Hodgkin's lymphoma. He was stage 3 BS. So he was a case of early relapse of Hodgkin's lymphoma. We gave him 2 cycles of nivolumab and bendamustine, post which he cleared his disease sites. After this, he underwent autologous stem cell transplantation and received consolidative RT. And he was kept under follow-up. But 8 months after receiving RT, he again presented to us with lymphadenopathy and constitutional symptoms. Biopsy of the lymph node was suggestive of Hodgkin's lymphoma. This time, PET scan done showed stage 4 BX disease. There was extensive disease involving multiple nodal sites as well as bone marrow. He was rechallenged with nivolumab bendamustine, but since the disease was so extensive due to the heavy disease burden, he ultimately expired after first cycle of nivo bendamustine with the high disease burden. We were not able to salvage him even after giving nivolumab bendamustine because his disease was very extensive. So these were the three cases I had to present. Thank you.
Thank you, Aditi. I think you have set the tone for the discussion and for Sam to present his, the options, various options that are available. And I think through all the cases, we kind of identified, how chemo has helped in salvage, how immunotherapy has helped in salvage, and how immunotherapy also did not help in some conditions. So I would request Dr. Sham to take over now, and you may please share your screen.
Sure.
And meantime, If anybody has any questions or queries, please put them on the chat box. We will take it after this talk by Dr. Sam.
I need permission to share. Oh, right.
Manisha, can you please
Yeah,
do that?
Yes, yes, sir. I have given the permissions. You can share.
Right. Yeah. Could someone confirm if the screen is visible?
Yes.
Right. Thank you. Yeah, good evening, everybody. So let me just start off with the presentation. So yeah, I would be discussing about relapsed refractory Hodgkin's lymphoma. Background, we all know that majority of children and young adults with classical Hodgkin's lymphoma are cured with first-line treatment. I mean, in contemporary, with the use of contemporary protocols, we are looking at outcomes as high as 90% plus. And the relapse rate, of course, is only 10% or probably even lesser when you are having a low stage or a low risk disease. And once you have an advanced stage disease, the chances of subsequent relapse is anywhere between 15 to 20%. So this is what is the relapse rate, what we would experience when treating Hodgkin's lymphoma. Then what do we need to know? What information do we truly need when we start treating a patient of relapsed refractory Hodgkin's? The one is the time to relapse, when the relapse actually occurred. What was the prior treatment which the patient had received? The stage, both at the initial therapy as well as at relapse, whether the relapse has occurred within the previous radiation field, if at all the patient had received radiation previously. What was the response to the salvage therapy which was given? So these are some of the information which one would need to prognosticate as well as plan therapy for patients with relapsed refractory Hodgkin's. Of all of this, the most important prognostic factor, I would say, would be the time to relapse. So classically, they are risk divided into three groups: the primary refractory, early, and late relapses. And primary refractory, as one could understand, is the group which would do the worst, and it is often defined as when there is progression within treatment, during treatment, or within 3 months of completion of treatment. The outcomes are not more than 30 to 40% in this subset. Whereas early relapses are relapses which occurs within a year, and late are relapses which occur beyond a year. And the best outcomes, of course, are for the late relapses. And if you were to risk group these patients, one could probably refer to the document by the Euronet group. They divide patients into a low risk group. So these are patients who have received probably minimal chemotherapy at the initial time point of therapy. They do not have much disease burden at the time of relapse. They have not received RT or probably relapsed outside the RT field. So these are a good risk group or the low risk group, and more often than not, they can probably be treated with more chemotherapy because they have not received much, and probably a radiation as well. Then Euronet calls the other group as the standard risk group, which, I mean, it is akin to high risk probably. And these are the patients who progress on treatment or who have received good amount of therapy at the initial time point, but still continue to relapse, or they have extensive disease at the time of relapse, or relapsing within the RT field. So this is the group, and which would require something more than your standard salvage chemotherapy. And historically, these patients have been offered high dose chemotherapy with stem cell rescue. So as I told you, the 10% of the low risk is a very small subset, and a good proportion of your patient would probably fall into the standard risk group. So how does the treatment of Hodgkin's lymphoma look overall? So, of course, you give upfront chemotherapy, the patient relapses. The first thing which we would probably do is to give salvage chemotherapy. If it is a low risk, we can end treatment with radiotherapy. If it is not a low risk, patient would need high dose chemotherapy with a stem cell rescue, and something post these autologous bone marrow transplant as a consolidative therapy. What has been used in many studies and reported is again more radiation therapy. And if all these fail, then we have to probably consider patients for an allogenic stem cell transplant. So this is how the traditional workflow for relapsed refractory Hodgkin's has been. First, about standard dose chemotherapy. So what are we looking for when we decide on a salvage regimen? It should not have much toxicity. Of course, the efficacy should be really good, because a good proportion of patient would need a bone marrow transplant. It should not impair the ability to mobilize stem cells. And of course, the late effects of this chemotherapy should not be much, because you are going to give them probably much more therapy which would have late effects. So the options, there are no standard salvage chemotherapies, but they are often grouped into cisplatin based, ifosfamide based, or gemcitabine vinorelbine based regimens. So this table shows you the summary of all the regimens which are available. I'm pretty sure even in this group, many of you would have used many of these regimens, chemotherapy-based salvage regimens. So one thing which is common and which stands out in all these regimens is the complete remission rate. So if you can see, the overall remission rate is hovering anywhere between 20 to 60% in the maximum. So this remission rate is quite important, because this ultimately defines or determines what the long-term outcome is, as you can see. And the remission is, at least in today's era, is defined based on PET-CT. Those who have a complete remission on PET-CT or PET negativity would go on to have a good long-term outcome, anywhere between 70, 80, or probably even 90%, even at relapse. Whereas those who do not have a good remission rate would not have great outcomes. And that is why a good remission is quite important, even for patients with relapsed refractory Hodgkin's. So then the question arises, do we have better options to standard dose chemotherapy? Then the options would include a CD-directed therapy, and the drug is brentuximab vedotin. And then the PD-1 blocking antibodies, which are the immune checkpoint inhibitors. And in Hodgkin's, what we have is nivolumab and pembrolizumab. Of course, you can use all these agents as an individual therapy, or we could combine them with a standard dose chemotherapy. Starting with brentuximab. So this is the data of using brentuximab as the single agent. This study was the pivotal study which led to the FDA approval of brentuximab. Again, as I go on with this talk, you would see me quote a lot of data from adult studies, because majority of the data in pediatrics relapsed refractory, in relapsed refractory Hodgkin's, comes from our adult colleagues. But nevertheless, I would try to do, compare and correlate as well. So this study enrolled predominantly young adults, adolescents, and adults. A recurring thing again would be, in early phase studies, patients who had failed multiple lines of therapy would only be enrolled. As you can see here, patients even failed high dose chemotherapy and transplant. The dose of brentuximab was fixed at 1.8 milligram per kg. And the overall response rate in the study was 75%, but the complete remission, that is the CR rate, which is what we are looking at to improve outcomes, was only 34%. Nevertheless, in 2011, this led to the approval of brentuximab vedotin for relapsed refractory Hodgkin's. The other lymphoma which they're talking about here is actually ALCL. So the 5-year progression-free survival was subsequently reported for this study, and it was only 22% with the use of single-agent brentuximab. And there were some in vitro studies which showed that drug resistance was being developed even for this drug. So with this study, what we got to know was brentuximab can be used as a salvage when patients are failing high-dose chemotherapy. However, what happened was in the real world, brentuximab was not used that late. It was probably added to salvage chemotherapy itself, or used as an alternative to it. So the question is whether we can use it in the first line rather than, reserving for second or subsequent failure of therapy. Do we use it alone as it was used in the pivotal study which led to its approval, or can we combine with chemotherapy? If at all we combine it, do we combine it together, or you give one after the other? That is, you give brentuximab followed by sequential therapy. So these were the questions which were actually happening. I mean, these were the burning questions. So in this table, I've kind of highlighted what has happened. When you use brentuximab as a single agent, the CR rates were probably 30-40%, but once you combine them with chemotherapy, the CR rates increased to as high as 60-70%. And various combination of chemotherapy were tried. Most of these studies involved adult patients, but some of them included adolescents as well. So this was a combination therapy. Now, this table highlights the successive therapy. That is, in the sense, once you initially use brentuximab, there would be a subset of patients who don't respond to brentuximab. Subsequently, what you do, you give them chemotherapy. So this was the sequential therapy, trying brentuximab followed by the chemotherapy. So as you can see again in the CR table here, the CR rate post brentuximab was 27%, and when you did a sequential approach, the CR rate shot up to as high as 70-80% in all of these studies. So the next group of drugs would be immune checkpoint inhibitors. As I told you, there are two drugs in this: nivolumab, which was initially FDA approved in 2016, and very soon the next group of the next drug, pembrolizumab, also received approval in 2017 for relapsed refractory Hodgkin's. So these were the two pivotal studies which explored nivolumab in relapsed refractory Hodgkin's. One recurring theme in both these studies is that it was not only used for patients who failed high-dose chemotherapy, it was also used for patients who failed brentuximab. So nivolumab was, even in the early phase trials, was explored as a therapy for patients who were failing brentuximab. So most of you would know the standard FDA-approved dose for nivolumab is 3 mg per kg. It needs to be administered every 2 weeks, and that is how it was administered for both these studies. And this study led to the accelerated. Both these studies led to the accelerated approval, FDA approval of this drug. Again, when used as a single agent, the CR rates were not great. It was 17% in one and 9% in the other. Another important point which I would like to highlight here is there was always a concern of added toxicity when nivolumab was given post allogenic transplant or pre-allogenic transplant because of the increased risk of GVHD. We still do not have enough data to say that it is safe, but this study was able to offer transplant for about 1/4 of the patient. But unfortunately, the long-term data which published did not talk about the toxicities secondary to this. Another point which is worth highlighting here is what happens when you discontinue nivolumab. So as you can see, 4 of 12 patients who discontinued nivolumab relapsed. But what is interesting is when they were re-challenged subsequently to nivolumab, they were able to attain remission. So there is some hope that a subsequent challenge of nivolumab is possible. And again, this comes from the limited data from the Checkmate study. So again, what would happen if you can combine nivolumab with more chemotherapy, similar to what we saw with brentuximab? As you can see, when nivolumab was used as single agent, the CR rates were probably 20-30%. But if you were to combine with chemotherapy or use it sequentially, the CR rates considerably improves to as high as 90%. this was the one of the COG studies, which was the Checkmate 744 trial. This included patients from both the North American and the European group. This part of the study was restricted to the high risk, the so-called high risk relapses, that is, who would probably require high dose chemotherapy and autologous transplant. So that was the strategy. In this study, the goal was to avoid chemotherapy. So as salvage, patients received both nivolumab and brentuximab together. So that was the theme. And when that was done, about 59% of the patients achieved complete remission. And those who did not receive complete remission were intensified, and the intensification included adding bendamustine to brentuximab. And following this, almost a good 94% of the patient achieved complete remission. Most of them could go ahead for transplant. So the question to me is the response rate of brentuximab and immune checkpoint better than either of them, as I showed you previously with chemotherapy alone? Because if you use immune checkpoint with chemotherapy, your standard salvage chemotherapy, your remission rates are still 90-95%, as I showed you in the previous slide. So I did speak about each of this separately, but which is better? All of you would have read the most recent NEJM publication. Again, this is not in the relapse refractory setting. It was used in the upfront setting. And clearly, when nivolumab was added to AVD, it outperformed brentuximab in AVD in the frontline setting. What about in the relapse refractory setting? So this was not nivolumab, but this study explored pembrolizumab. This was in relapse refractory setting. This included patients, again, this was more than 18 years of age, included patients who had failed first or subsequent lines of therapy, which includes high-dose chemotherapy and stem cell rescue. And in this study, as you can see from this graph, pembrolizumab did better than brentuximab. So what about nivolumab versus brentuximab? There is no head-to-head comparison here. All I've done here is to compare the two pivotal trials which led to the FDA approval of both these drugs in relapsed refractory Hodgkin's. As you can see, the duration of remission is, of course, better with nivolumab. The progression-free survival is better with nivolumab. The response, if restarted, of course, as I told you, is better with nivolumab. We do not know that with brentuximab, because most of the patients who fail brentuximab will probably receive immune checkpoint inhibitors. So that is that. Again, this is not an head-to-head comparison. I've just compared two different studies. So where do we use checkpoint inhibitors? Patients who are brentuximab naive, of course, we can use it. Those who have failed brentuximab and as a bridge to autologous stem cell transplant, they can be used. Then the question would be, can you use immunotherapy as an alternate to immune checkpoint inhibitor to bone marrow transplant if the remission rates and outcomes secondary to these drugs are so good? We all know that the long-term morbidities are very high in relapse refractory Hodgkin's. This was one of the studies from the St. Jude lifetime cohort, where any toxicities, including secondary malignant neoplasms and cardiopulmonary disease, had all shot up several folds when you give salvage chemotherapy, especially autologous and allogenic stem cell transplant to these patients. So that brings us to the question, do all patients with relapsed refractory Hodgkin's lymphoma need this high-dose chemotherapy? So these were three major publications which just came. Actually, I got access to this yesterday. They got published in JAMA Oncology last week. So let me try and take you through each of these publications. So the first is the much awaited Euronet study, and this was in the relapse refractory cohort. As you can see on the left side flow diagram, they broke down their patients into 3 risk groups. The RG stands for risk group. Risk group 1 is the good risk. So these are patients who relapsed late and they hardly received any chemotherapy in the first line. The risk group 3 are the one who progressed on therapy. So these are probably the worst performing group. Then there is a whole mixed bag called as the risk group 2. And as you can see, majority of the patients were in the risk group 2. So what chemotherapy did they receive? They received IEP, which was ifosfamide based and alternating with ABVD. So most of these patients in the front line had received the OIPA-COPDEC regimen. They were all part of the Uranet PH1 and PH2 study probably as well. So it was the OIPA-COPDEC, and for salvage, they were given ifosfamide based and ABVD based therapy. So what is interesting again here, the risk group 2, they were risk stratified further based on their early PET response. So if they had PET response, if they had a good response, they were called as low risk and they were treated similar to the RG1. And if they did not have a good response, they were treated similar to RG3. So the treatment in RG1 and good RG2 would only be chemotherapy and followed by radiation therapy, whereas the treatment for the high risk group would be autologous stem cell transplant in addition. So this was the outcome. Going back to the table, as you can see, a good proportion of the patients who had a good response went on to receive autologous transplant. This was outside the trial protocol. Nevertheless, that happened. Of course, those who did not have a good response in the interim PET did receive autologous stem cell transplantation. So if you can see those who are low risk in this graph here and they received RT alone, they had an outcome as high as 90%. And those who are low risk, so again, low risk are the one who had very minimal disease or who are risk group 2 but responded very well to salvage chemotherapy. They also had an outcome of 90% only. So doing an autologous transplant did not matter much as long as you are a low risk as defined by Uranet. But again, another point to be noted here, if you are high risk, no matter what, the outcomes were only 53%. So high risk, what did they receive? They received only chemotherapy followed by autologous bone marrow transplant and radiation therapy. With that, the outcome was only 53%. So as you can see, the risk group 3, which is primary progressive, the outcomes were dismal. It was only 35%, whereas risk group 2, which was the majority of the patient, if they responded well to therapy, the outcomes were excellent, 90%. And if they had poor response to therapy, even if they underwent an autologous stem cell transplant, the outcomes were hovering anywhere between 60 to 65%. So what were the lessons learned in the Uranet PHL1 study? If you're a low risk group, so how do you define it? Anybody who had a late relapse after minimal therapy or did not have primary progressive disease, but had a good response. And the good response was quite stringent in the study. You have to be DS1 or a maximum of DS2 on early PET, which was done following 2 cycles of salvage. So these patients would approximately constitute 40%. I mean, these are numbers from the study, and they would have good outcomes as high as 90% progression-free survival with chemotherapy alone and, of course, and consolidative radiation. Whereas the high risk group, this includes the primary progressive or the above group who did not respond well on PET. This would constitute the majority, which is 60% of the patients. And with the therapy, that is standard chemotherapy and high dose chemotherapy and RT, they would only have a 50% outcome, which means this group definitely needs something more than this strategy. Now, talking about the other publication, which again happened, was the other arm of the COG trial. I did discuss where the COG did use a non-chemotherapy approach. So this was the other arm in the low risk group, and the low risk here again was very similar to the Uranet strategy, but not exactly the same. I have just jotted down what are the low risk group here, and the treatment was very similar. All of them would receive a chemotherapy-free induction, which was nivolumab and brentuximab. And if they had a good response, they would be consolidated with nivolumab and brentuximab and radiotherapy, where if they do not have a CMR, they would receive an intensification with bendamustine based, so a very minimal chemotherapy and CMR. So the results, the CMR rates in the study was 95%. There were hardly 3 patients who required the intensification with bendamustine, and the 3-year progression-free survival was excellent, and it was 95%. Again, so this was another study. This was recently discussed in the International Society of Hodgkin's Lymphoma study 2024. So what happened was, initially patients, this included adolescents, young adults predominantly. So patients received pembrolizumab with GVD based salvage. As you can see, the progression free survival was 100%, but at this time point all patients received pembro GVD followed by autologous bone marrow stem cell transplant. So what happened, they amended the study and they decided patient who had a CMR would not undergo transplant, and they would continue on pembro GVD. So these were the updated results, which was just published last year. It is just as an abstract again. So what happens, the PFS did drop. So the PFS was approximately 50% at 2.5 years. So there are 2 ways of looking at it. So the half of the patients did not require a consolidative bone marrow transplant. That was one way of looking at it. And the patients who probably performed worse were those who were stage 4 at relapse or progression. So a good proportion of them progressed. Probably these patients cannot get away with a consolidative transplant. And most importantly, 9 out of the 10 patients who progressed were successfully able to proceed with subsequent bone marrow transplant. This is again tells that once a patient fails checkpoint inhibitors, they can regain that remission once you re-challenge them with checkpoint inhibitors. So moving to the next part of my talk, so what more do we have to give to patients after they finish their consolidative bone marrow transplant? Is there something more? So this comes to the concept of consolidation or maintenance therapy. Again, the pivotal study was the Athira study. Most of you would be knowing it. This was a phase 3 randomized controlled trial. This explored brentuximab as maintenance in relapsed refractory Hodgkin's. Again, this was a study performed predominantly in adults. They were all more than 18 years of age at the time point of enrollment. And it was a phase 3 RCT. So what I'm highlighting here is all patients were enrolled after they completed bone marrow transplant, and they were randomized between a placebo arm and a brentuximab vedotin. But another point I would like to highlight here is they need not have been in CR to be enrolled into the study. That is, patients who had stable disease or even partial remission could also be eligible for the study. Again, brentuximab, the standard dose were given. They were given up to 16 cycles, that is roughly a year and a half of brentuximab. As I pointed out, only 1/3 of the patients had complete remission at the time of enrollment. And another important point, which I failed to point out previously, is none of these patients had received previously any form of immunotherapy. That is, neither did they receive brentuximab, nor did they receive immune checkpoint inhibitors at the time point of enrollment. That was an exclusion criteria in the study. Another important point to be highlighted, about 33% of the patient discontinued therapy, mainly because of toxicity of brentuximab. As most of us know, that the most important toxicity is neuropathy. Nevertheless, brentuximab did extremely well when compared to placebo, and the progression-free survival was excellent. So if you were to tease out and find out who are the best, who would benefit the most with brentuximab maintenance, as you can see, the high-risk disease with high disease burden, those who are primary refractory or having an early relapse or having a very partial response, that is not CR before transplant, who are having B symptoms or extranodal disease, these were the patients who would benefit the most with brentuximab. Now, the question is, what is the utility of brentuximab in the era of immunotherapy? That is, if you are going to incorporate brentuximab and immune checkpoint as salvage during the time point of salvage, would brentuximab maintenance help? This was a large study. This was published in ASH last year in 2023. So if you can see, 46% of the patient received brentuximab and 18% of the patient received immune checkpoint inhibitors before autologous stem cell transplant. As I've highlighted, brentuximab did not improve maintenance, did not improve the outcomes for patients who had salvage which incorporated either brentuximab or immune checkpoint, whereas, of course, as the Athira study told, it did improve the outcomes of patients who did not receive these drugs during salvage time point. What about other drugs as maintenance, which is immune checkpoint inhibitors? So pembrolizumab has been explored. So in this study, unlike the previous Athira study, patients who had previously received brentuximab and immune checkpoint inhibitors were eligible, but nevertheless, the overall sample size was low, and the progression-free survival was excellent, 80% plus. Again, 20% of the patient had toxicity, and the percentage of discontinuation was 16%. This was probably slightly less than what the Athira study showed. Again, there are more and more studies which have explored these drugs, especially immune checkpoint inhibitors, let it be nivolumab and pembrolizumab, as maintenance therapy. And these studies were not as stringent as the Athira study, and they allowed a previous immunotherapy or brentuximab to be given at the time point of salvage. So that is that about immunotherapy as maintenance. Then the next question would be whether we could optimize the dose of immune checkpoint inhibitors. Do we truly need the 3 milligram per kg of nivolumab is another question. So these are the list of ongoing studies which are exploring a lower dose of immune checkpoint inhibitors across several diseases, not only Hodgkin's lymphoma. And these are probably the recent publications which have happened. Of course, one of that was from our own center, which explored the low dose nivolumab, fixed dose nivolumab. But again, there are studies. The one on the right was again recently discussed in ASH 2024. This was by CMC Vellore, which explored a fixed dose of 40 milligram nivolumab, predominantly in adults, and they showed excellent response rate. This is our own experience of using immune checkpoint inhibitors in relapsed refractory Hodgkin's in children. Over the last 3 years, we treated around 18 patients. We used a fixed dose, of course, of nivolumab, 40 milligram. We gave it on day 1 and day 15. We combined it with bendamustine. The median previous lines of therapy received by these patients was 1. 2 of these patients, Dr. Aditi had discussed as well. Most of these patients had advanced stage diseases and had B symptoms and would qualify as a high risk if one were to go by the Euronet definition. The median dose, if you were to calculate based on the body weight, was probably less than half of the FDA recommended dose. However, we had excellent response rate, the 93% CR after a median of 2 cycles. So this data is not mature. We just have the 1 year progression-free survival, and that was 88%, and the 1 year overall survival was 94%. Of course, there was only 1 patient who died due to a relapse, and that is the case we had discussed in the end. That child subsequently had a very high disease burden at the time of relapse, and we could not salvage, and there was a lot of comorbidities as well. So, is chemoimmunotherapy for relapsed refractory Hodgkin's feasible in India? I think the simple answer would be yes. We need to optimize the dose, not because we cannot afford it. Probably the answer is because maybe such high doses are not needed. So choosing the right patients is important. Not all patients would probably need immunotherapy. I did discuss the Euronet results where the salvage rates for some patients with relapsed refractory with chemotherapy itself is good. It is very important to be aware of the toxicities, immune related adverse effects is a reality. We did lose one child to pneumonitis subsequent to third cycle of nivolumab. I don't think we have enough data of using these drugs in an Indian setting. I think that is what the prospective registry, which the INFOC group is floating, would probably capture. So it is important to be aware of these toxicities. Of course, we need to discuss with the family the costs and the benefits of using chemoimmunotherapy is important. That the best way would probably to improve access through collaborative clinical trials. So this would probably be my last slide. So where are we? So this is where we are now. This would summarize what I have spoken in the last half an hour. Probably you would have a patient who with upfront chemotherapy is relapsing. We try salvage chemotherapy. Maybe we can incorporate immunotherapy along with chemotherapy at this time point only to improve the remission rates, because we know that remission rates would translate into a much better outcome. Of course, radiotherapy remains an important aspect of therapy. Those who can be cured or attain remission, the low risk disease can be consolidated with radiotherapy alone. Then there would be a large proportion of patients who would need high dose chemotherapy. The current standard of care, even with the use of chemoimmunotherapy, would be to consolidate with high dose chemotherapy and stem cell rescue. However, I've shown you some early data where some patients would probably get away without the need of this. And I mean, the advantage would be the subsequent remissions. These patients are good, and you would probably avoid long-term morbidities in some patients. And then what happens? Could you further reduce the risk of relapse post this autologous stem cell transplant? Probably yes. We could use maintenance therapy. Again, we need to choose which are the patients whom we would offer brentuximab. There is not much data again in the pediatric setting. All of the studies as maintenance which I have discussed with you have come from adults. We ourselves do offer nivolumab maintenance for 6 months at our center. We again use a much lower dose of 40 milligrams, and we give it only 3 weekly. And which maintenance therapy, brentuximab versus nivolumab? Probably avoid brentuximab if you have used it previously at the time point of salvage. Maybe immune checkpoint inhibitors are better. Of course, if the patient were to fail all these therapy, then the last resort would be allo transplant. Thank you. That would be the end of my talk.
Thank you, Sham. And since we are running a bit short of time, I would now invite Dr. Amita Mahajan to give us an update on the INFOG Hodgkin's lymphoma study. And Dr. Amita Mahajan doesn't need any introduction to this group, but just to complete the formalities, ma'am is a senior consultant pediatric hematology oncology at Indraprastha Apollo Hospital, New Delhi. And she's one of the board members at INFOG, the Indian Pediatric Hematology Oncology Group, a medical advisor to CAN Kids, KidsCan, and one of the driving force behind the INFOG Hodgkin's lymphoma study. Ma'am, over
Thank you. Yeah, thank you, Shruti. As everybody, Dr. Srinivasan has given an amazing overview of the whole scenario and of all the diseases we treat. It's Hodgkin lymphoma that's undergoing such rapid evolution that, the guidelines, the NCCN introduced child-specific guidelines only for Hodgkin lymphoma in 2021, and they had to be revised in 2023, way ahead of schedule. And Aditi has also shown us 3 cases, just highlighting that relapsed Hodgkin lymphoma is not one disease, and therefore one approach cannot fit all scenarios. What I hope to do very briefly over the next few minutes is to share, some data from grassroots level in India, and many of you have participated in the study. And we concluded the study last year, and I will share the data that up to date. Shruti, could you share? I think there is challenges at my end.
Sure, ma'am. Just give me a second.
So Hodgkin lymphoma, even in resource-limited countries, we know that it has excellent outcomes. We've been able to manage those outcomes for most of the patients at our center. Next slide, Shruti. But regardless of that, there is a proportion of patients who will relapse, and there will be some who have primary refractory disease. And to date, I mean, Euronet PHLR1 study may now become the standard of care, but to date, there has no clear definition of what is optimal treatment for a patients with Hodgkin lymphoma. For a long has been considered the standard of care, really based on these 2 studies which were done over 25 years ago. And this cockroach was largely based on these 2 studies. There were hardly any children, a few adolescents, of course, but the study concluded that for young adults and adults, consolidating relapsed Hodgkin lymphoma patients with autologous stem cell transplant gave significant advantage, and it came to be kind of known as the standard of care. Next slide. But increasingly, there was realization that at least in pediatric Hodgkin lymphoma, there is a cohort of patients that can perhaps have reasonably good survival without consolidation with transplant. And these are some of the studies that had looked at only salvage standard chemotherapy with one regimen or another, followed by RT. And you can see that they could show disease-free survival of 70 to even 100% for the very low risk cohort. Next slide, Shruti. So it was really based on this premise that there is a cohort of patients with low risk disease which may do equally well with conventional salvage chemotherapy and radiation. And we felt that it was very important to evaluate this in our setting, especially because of limited access to autologous stem cell transplant. So this study was designed with a risk stratified response based approach with the primary objective to prospectively evaluate the clinical course and outcome of patients treated using a risk stratified response based algorithm to determine factors that predict response to salvage chemotherapy. And as a kind of a byproduct, we also wanted to improve access to modalities such as radiation and autologous by guiding the patients to other centers if they did not have this facility. Next slide. So we chose to risk stratify patients into the high risk arm if they had primary refractory disease, if they had relapsed within 12 months of completion of therapy, had B symptoms, relapsed in an irradiated site, extranodal disease at relapse, or stage 4 disease at relapse. You may all recognize that, of these were the standard high risk factors considered at the time. But now the Euronet guidelines recommend that really only 3 factors, on of which, time to relapse and response to salvage treatment are the most important. Patients who didn't have any of these above factors were assigned to the low risk arm. Next slide. So this was a prospective memory-centric study. Gemcitabine was chosen as first salvage therapy because, as Dr. Srinivasan has shown, a number of therapeutic protocols have been tried, and they have delivered more or less similar overall response rates and similar complete metabolic response rate. So gemcitabine was chosen because of its safety, ease of delivery as a daycare procedure, and considering that many of our centers may not have ability to deliver very intensive chemotherapy protocols. ICE was put as a second line salvage therapy. PET-CT was made essential for both diagnosis and response evaluation, and patients who had high-risk disease or suboptimal response to the first two lines of therapy, regardless of the risk stratification, were allocated to proceed to autologous stem cell transplant after achieving complete metabolic response or at least a very good response. Next slide, Shruti. So this is just to show that, this slide, Srinivasan has also shown that whichever protocol you use, there seems to be a similar value. And we thought gemcitabine vinorelbine is the easiest low toxic daycare delivery protocol. Next slide. And this was also on the basis of this phase 2 study done by the COG, which had used gemcitabine vinorelbine. I just wanted to highlight the choice of the protocol because at that time there were many concerns that, whether this was a very mild protocol. But looking at, what was previously published, that's the one the study team opted for. Next slide. So this is the algorithm for the low risk HL that if all patients receive 2 cycles of gemcitabine vinorelbine upfront with response evaluation. Low risk patients, if subject to adequate response, were to receive 4 cycles followed by radiation, and high risk patients were to complete, as soon as they went into complete metabolic response, to proceed to autologous stem cell transplant. Next slide. So next, please. So there was a lot of concern at the time because autologous stem cell transplant was considered, like I said, in inverted commas, standard of care. And to give a treatment option without that, some of our colleagues had concerns about that. But those concerns were really relieved by these guidelines coming out in 2020, right after we launched the study, which again shared that the low risk group, could manage without autologous stem cell transplant. So I think we felt a little more comfortable treatment to this children. Next slide. So these were the panel recommendations. The approach that we had used in the study was kind of similar to the recommendation of the Euronet, the expert panel. Next slide, Shruti. So these are the results. The study, it's called 17. And the study went on for till 2023. As you may recall, that was the time we faced the pandemic. So our target patient enrollment was 100, but we achieved a number of 70 during that time period. And we elected to close the study in 2023 because the treatment for relapsed HL had evolved so much that we felt that it would be time to learn the messages from this study and move on perhaps to a new study which takes into account whatever recent advances that we are seeing and Srinivasan has summarized. So of this cohort of 70 patients, which was from 70 patients from 13 centers, 2/3 were high risk, 1/3 being low risk. 62 had received ABVD as frontline therapy and 11 had received radiation as frontline therapy. Next slide. Shruti, could we? Yeah. So of this cohort, 80% received GVS first salvage therapy. 20%, based on the consultant choice, they either added a third drug or used an alternative protocol, which we documented as protocol violation. But nevertheless, we looked at all the results. The overall response rate, a complete metabolic response and partial response was seen in 71.4%, and it did not matter which protocol they used. So again, highlighting that you either have chemosensitive disease or not, and then any of the agents, effective agents, will probably give you the same rate. Next slide. So 12 patients were switched to ICE protocol because of suboptimal response, but only 2 of them went on to develop good response. 10 of these subsequently received immunotherapy. Of the entire cohort, based on their high risk stratification or suboptimal response to 2-cycle GV. 51 were assigned to autologous transplant, but only 15 could undergo the procedure. Again, highlighting the difficulties, and these were, of course, significantly accentuated due to the pandemic. Next slide. So this is again just showing that the risk did impact the response rate significantly. Next slide. And again, whether they had received patients who had received ABVD as frontline therapy, because it's much less intensive. With subsequent treatment, they were more easily salvageable than alternative chemotherapy protocols, which would usually be the uronate protocol in our country. Next slide, Shruti. So patients, of course, previous radiation, because there wasn't that big a number, we could not demonstrate a significant statistical difference in outcomes. Next slide. So age also again did not matter. So this is the survival. I think we have maybe missed a couple of slides. So patients who were assigned to the BMT arm, if they did not proceed to BMT, there was a significant decline in survival. So as Srinivasan has highlighted, that regardless of what strategy we use, there will be a proportion of patients who will require autologous BMT. Next slide. So the overall, at a median of 32 months of follow-up, the overall survival and event-free survival are 75.7% and 68.6% for the whole cohort. For the low risk arm, this is about 83%, the overall survival, and the overall survival for the high risk arm is this is at so the overall survival for the low risk arm is at 83.6%, and for the high risk group it is about 65%. So what we could finally conclude is that GV can achieve a response equivalent to other protocols. Complete metabolic response, again highlighted as in previous study, could be achieved in only 37.5% of patients. Only 2 of the 12 patients switched to more intensive chemotherapy achieved complete metabolic response. So probably switching to alternative treatment protocols at this point, maybe immunotherapy would perhaps be more prudent. Next slide. So this is again what I have summarized. So again, just to highlight that, for us, with the challenge with access to autologous stem cell transplant, we need to even more aggressive look at salvage chemotherapy treatments. And that is why the study collecting real world data on immunotherapy is very important, to know the settings that has been used, the response that we have seen, because our experience is still limited with these agents. And I think we can learn so much from each other's experience. I think we hope that we will be able to also do a prospective study of fixed dose Nivo plus bendamustine, because like Srinivasan has shown, this has shown excellent response. Many of us are using this, and in fact that was the premise, to collect the real world data, to make it a springboard to take a prospective study with this as our first salvage regimen, which is not just cost effective but also has a very low toxicity. And in terms of cost, the Nivo may be expensive. A low dose Nivo with bendamustine combination really compares favorably to any other salvage regimen in our setting. Next slide. And I think that's the last slide, just to acknowledge all the centers who participated. CanKids KidsCan, who have been the principal sponsor for this study. Peter Cole, who reviewed our study, and he'd done the COG phase 2 study for relapsed Hodgkin lymphoma. And I'd just like to finally say thank you for all of you to staying beyond the time of this session. Thank you so much.
Thank you, Amita ma'am, and thank you for giving us that update. And it's quite heartening to see that with a simple chemotherapy that can be given on a daycare basis, we were able to achieve good results in our resource limited setting as well. So since it's already 8:10, if there are any burning questions, any pressing questions, you can put it in the chat box, and we can carry on with that. So we have one question